On behalf of the entire team of the Grey Medicos, I would like to extend a warm welcome to the guest speaker and all the participants present here. The Grey Medicos, a platform formed by the collaboration of medical students from different medical colleges, resembles a colorful rainbow which brings together bright, colorful, and curious minds to discuss clinical cases. Today, we are going to have discussion on topic inguinal hernia. We have Dr. Rajesh Adhikari as our mentor. He is currently working as a first-year resident in Department of Surgery at Gandaki Medical College, Pokhara. A warm welcome to you, sir. We also welcome our presenter, Dr. Liladhar Oza, who is currently working as an intern at Gandaki Medical College. Now, I would like to hand over the floor to Dr. Liladhar Oza and request him to start his presentation without further delay.
Namaskar and good evening to everyone. Am I audible? Sorry, Suniraso. Suniraso sabele.
हजुर सुनिरहेछ
Okay. So shall we start? मैले चाहिँ co-host भन्नु पर्यो है के रे host okay screen देखियो सबैलाई देखिया छ
Yes, sir, देखिएछ।
Okay, first of all, thank you for all your patience. धेरै ढिलो भयो अलिकति है Okay, without any delay, let's start our presentation on inguinal hernia. So here is the case. A 69-year-old male residing at Dovila, Pokhara, laborer by occupation, follows Hindu religion, has education of primary level, married, came to GMC OPD with chief complaint of swelling over right groin for 1 year and pain over right groin for 1 month. And on history of present illness, he has swelling over the right inguinal region for 1 year, progressive in nature, increased during coughing and lifting weight, reduced while lying, and it was associated with pain, no history of swelling in left groin or elsewhere in the body. He also complains of mild dull aching pain in right groin since 1 month, which increases on straining and relieves on lying down position. He didn't complain of abdominal fullness, hard stool, vomiting, increased frequency of urination, and burning of micturition. There is no history of other abdominal surgery done in the past. It's a known case of chronic obstructive pulmonary disease since 15 months and also a known case of hypertension for 10 years. There was no similar history in the family. There are 4 members in the family, and on his personal history, he is non-vegetarian by diet, alcoholic since 8 years, and he used to smoke since 8 years with 12 pack year. Bowel habit is normal, micturition is normal. His appetite is good and normal sleep pattern. On treatment history, he regularly takes levosalbutamol and budesonide inhaler since 1 year and amlodipine 5 mg since 8 years. On allergic history, there is no documented history of the allergy yet. On examination, it was done after taking consent from the patient, and we did well exposed and in well.
Can we talk on history for a little bit?
Okay, yes, we can.
Yes, so in history, there is you have taken that it is 69-year-old male residing in Dovila, laborer by occupation and Hindu by religion. Does this have any significance, special significance over on this case?
Yes, guys, you can answer. Anyone, please? Achal? Hello, everyone is mute. Anybody can answer. Let's make it interactive.
Okay, anyone can participate. Any valuable opinions are invited.
Is it due to the weakening of the muscle due to aging?
No, yes. First of all, the age is 69-year-old, so the age has a special significance over here. So if it is in old ages, due to the weakening of the abdominal musculature, the predominance of the direct inguinal hernia will increase rather than indirect inguinal hernia. So it is in this case the age has one significance, and another is sex, as he is a male. Is there any significance in this case? In immunoscrotal swelling, if a male has a inguinal swelling, and if a female has a inguinal swelling, what are the possible causes? What are the possible uh, diagnosis that comes in our mind? Any inguinal swelling or groin swelling in male and in females.
Which one is more common in female, guys?
Any
Which
groin
organ?
swelling that is more common in female, that has more incidence in female.
Please participate. Whatever answer, we don't make any judgments, anything like that. Just this is a teaching learning platform, right? So it will be better if you all participate. Whatever came in your mind, you can answer.
Lila, can I go through?
Yeah, sure.
Okay. In female, there is a big there is increased incidence of the femoral hernia. The femoral hernia is mainly prevalent in the female population, whereas inguinal hernia it is more prevalent in male population. And your history also gives the occupation as a laborer, which gives a history of like hardworking population with excessive physical exertions, which can lead to weak musculatures in a long period of time. That is also a significance. And the main complaint is swelling over the right groin for 1 year and pain over right groin for 1 month. It also gives a history of progressive increase in swelling. There is progressive swelling that can give that can give history to like inguinal hernia, that is progressively increasing in nature. Okay, you can carry on. And Lila, you can carry on.
Yeah, on this part, this on history of present illness, it is also significant. Can you please elaborate on this term?
Which term?
Like there is coughing. It's increased during coughing, right?
Yeah, and another is like there is progressive in nature, and there is increased coughing, increase during coughing and lifting. The patient, as you have explained, that there is a patient had a history of COPD, and he had persistent coughing that can also lead to the increase in intra-abdominal pressure, which can lead to the herniation of the intestinal content from the defects, weakening defects, which is weakened by the long lifting weight. And as it is, as you have given the history, that the size usually increase during coughing. That is, it gives the history of coughing pulse, reduced while lying. It gives a history of it gives a clear it gives a history of hernia. It can be either inguinal or femoral, but it gives that the after increasing the intra-abdominal compartment pressure, the size of the swelling increases, and while decreasing the abdominal compartment pressure, it usually decreases by lying. So it is like it is the swelling which is related to the abdomen and inguinal region, and it is associated with pain. You have given the history of which is associated with pain. So that can be one feature of either obstruction or irreducibility. But you said it is reduced while lying, but associated with pain. It's usually associated with pain. So the pain is usually started in that kind of swelling when it is associated with the obstruction or strangulation. And in the inguinal region, if it is associated with pain, you have to also think about it, the inguinal lymph nodes. Either it can be a inguinal lymph node as well, the painful tender inguinal lymph node. If a swelling in the groin, which is associated with pain, that can be inguinal lymphadenopathy as well, but it is not reduced while lying, but increase during coughing and lifting. It is not found in inguinal lymphadenopathy.
Okay. So
Okay, and is there any significance of history of abdominal surgeries on past? In the past history, there is he has taken, like, there is no history of other abdominal surgeries done in past. Is there any significance of this history being taken here?
Incisional hernia may be there.
Yeah, one can be very nice. One can be incisional hernia whenever there is like another operation has been done, there can lead to the defect from the incisional site that can lead to the incisional hernia. And other causes, any other significant, any significant surgery that can lead to the inguinal swelling.
Appendectomy, weakness of the abdominal muscle.
Okay, I'm asking, is there any specific surgery that will lead to inguinal swelling?
Appendectomy.
Yes, appendectomy. In the appendectomy, there is a chance of injuring one specific nerve, which can lead to inguinal hernia. What is the nerve?
Iliohypogastric.
Yes, iliohypogastric nerve. There is a chance of iliohypogastric nerve. So you have to take the history of any past history of any past appendectomies or not. So if there is any past history of appendectomy, that can also be due to the inguinal swelling. Inguinal swelling can be due to the injury of the hypogastric nerve. And he is a known case of COPD since 15 months. The COPD is also significant in this case. It is persistently increasing intra-abdominal pressure due to persistent coughing. And he's a known case of hypertensive.
Can you also elaborate this negative history, like he didn't complain of abdominal fullness? What are these significance?
Negative history?
Yeah, in negative history.
No history of swelling in the left groin or elsewhere in the body?
And that part and this one also, the
Okay,
abdominal fullness.
He didn't complain of abdominal fullness, hard stool, vomiting, increased frequency of urination and body micturations. Yeah, the abdominal fullness should be taken, because if there is like features of the obstruction or strangulation, then the abdominal fullness will occur. So that you have to take the abdominal fullness, because if there is strangulation or obstruction, the obstructive features in the obstructive features will arise eventually, and hard stool, vomiting, these all are related with the obstruction, the obstructive feature which can be caused by obstructed hernia, and increased frequency of urination and burning micturition. We have to rule out the prostatic enlargement in this kind of swellings. If there is any kind of swellings, we have to also rule out whether bladder is involved or not, whether the prostate. Sometimes the bladder will be the content of the hernia, and sometimes we have to rule out the prostatic enlargement. So we have to take out the history of frequency of urination, reduce the stream of urination, burning micturition to rule out the prostatic enlargement. And to rule out the obstructive feature, we have to take the history of abdominal fullness, vomiting, that kind of history should be taken.
Family history?
Yes.
On family history, what is the significance?
Okay. In family history, there is no any relation of the genetic defects with the uh, abdominal hernias or inguinal hernias, genetic in the genetics, but family.
Like that those
Any special things if you can exchange?
yeah, I think this on this collagen disorders.
Yeah, collagen defects. Yes,
Sir.
collagen defects that can also give to the history of the inguinal hernias, collagen defects. Yes.
Okay. On personal history.
Personal history. Non-vegetarian by diets. Alcoholic since 8 years. Smoker since 8 years with 12 pack per year. Okay. Decrease appetite. Normal shape, bowel habit normal, micturition is normal. So the bowel habit is bowel habits. The history of bowel habit is especially for like to rule out the obstruction, irreducibility and obstruction. The bowel habit will be altered. In benign enlargement of prostate, the urinary habit will be altered, and the smoking that usually relates to the chronic obstructive pulmonary disease. Alcoholics, that also leads to the uh, um, increase in intra-abdominal pressure that can be related to the alcoholic liver disease. Okay.
And one thing, this is smoking can also cause this this healing, tissue healing.
Yes. Alcoholism can also lead to the decreased healing when any that can lead to the incisional hernias.
Smokers.
Smokers.
Collagen related, especially this, right?
Yes. Okay. Amlodipine.
Treatment history.
Okay.
I mean, so we have to. I think we are checking that whether the its just condition is good or not. How much is it significant? Like this, he's taking regularly this medicine, or he didn't take any medicine. Means there is any correlation. Like if he didn't, he's diagnosed, but he didn't consume any medicine, then his future is you will have you will not good chest condition, means you will have more increased abdominal pressure like in daily life.
Yes. How regularly it takes and how often
how compliant is depending upon that.
The compliance one is the compliance of the patient, and another is like what is the chronicity of the COPD. That will also depends on how often he takes levosalbutamol and budesonide inhaler. How often he has to take it. He has to take daily, or he has to take whenever he needed. That also gives the chronicity of the chronic obstructive pulmonary disease. And another is compliance of the patient, how compliant he is with that treatment. Okay.
Okay, on examination.
We move on examination part, but I think everyone please everyone give their opinion and make this presentation a little bit more interactive. It's 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 not being uh, too much interactive.
Yeah, okay, please, everyone.
Please, anyone who have creative opinions, who have different opinions, please share their views on this examination part. I think you can ask any queries to the presenter as well. Okay.
Okay, till now, if any confusion, please raise your questions.
Yes.
We will try to answer on exam on history part.
On history part.
Hello, I have to ask one question that I have read in one book. In obese patient, the herniation is quite less than in the thin-built person. And here we have also taken a history of BMI. And
Yes.
any views regarding it?
Yeah, I have not got any you clearly. Please repeat the question again.
त्यो ओबिज पर्सनहरुमा चाहिँ युजुअली हर्निएसन अलिकता थिन पर्सन भन्दा कमी हुँदो रहेछ के अनि त्यसको लजिक बिहाइन्ड इट के थाहा थिएन के
obese person अब that the hernia is like it is usually defect. Okay, so it can be defect from any ventral surface of the body, which leads to the communication with the abdominal cavity. So the subcutaneous tissue also leads also makes a barrier, but it's not that strong as like the aponeurosis and fascias of the muscles, but it is also one barrier. Okay, subcutaneous tissue, how thick is the subcutaneous tissue? It's also one of the one of the parameter, but I don't have any clear-cut idea about like it is strictly it has a clearly a role on incidence. The BMI has a clearly role in incidence of inguinal hernia. It is usually related with the defect in the transversalis fascia and the external oblique aponeurosis. Regarding with the inguinal hernia, it is totally related with the weakness of transversalis fascia and external oblique aponeurosis. So I don't think there is a clear-cut relation between the body mass index and the incidence of the inguinal hernias. If you have any that kind of studies, you are welcome to share.
Any question, please? So shall we move on, or
shall we move on?
Okay, sir.
okay, on general condition, patient is moderately built and well nourished with BMI 24.7 kg per meter square, is conscious, well oriented to the time, place, and person, and his vitals are stable. Okay, there is no any. Okay, on this. On cardinals, he's not pale, nor neither icteric, no cyanosis, clogging or edema and dehydration, and no lymphadenopathy. On local examination of the inguinal region, we did first in standing position, then in supine position, and exposure is from umbilicus to the mid-thigh. On inspection, there is a piriform shaped swelling present over right inguinal region, extending from above the middle half of inguinal ligament down to the scrotum, and it was approximate size of 4 by 3 centimeter. Skin over the swelling is normal. Swelling expand on coughing. No visible peristalsis seen. And left inguinal region appeared to be normal. Penis is slightly pushed toward the left side. On palpation, a swelling of 4 by 3 centimeter present above medial to the pubic tubercle, extending into scrotum up to upper pole of the testis, right testis. And there is no local rise of temperature, no tenderness. Swelling was soft and elastic, not possible to get above the swelling, and testing is felt separately from the swelling. And there is expansive impulse, cough impulse is present. Swelling is reduced manually with gurgling sound. Differing occlusion test positive for and G-man test shows impulse on index finger. And on examination of the left inguinal scrotal region, no inguinal or scrotal swelling on left side, no cough impulse. On percussion was not done due to the pain, and auscultation gurgling sound heard. On examination of the external genitalia, scrotal skin was normal. Testis, both testes were normal. Spermatic cord normal on both sides. Penis normal. No phimosis. Meatus is normal and no discharge. Urethra seems to be normal. No strictures, and there were no inguinal lymph node enlarged on both sides. And on digital rectal examination, there were no fissures and sentinel pile. On palpation, anal tone is normal, no growth, prostate normal. On systemic examination, respiratory system, bilateral equal chest movement was there, normal vesicular breath sound, bilateral decreased breath sound with long expiration, which was present over bilateral lower lung field. On abdominal examination, equal movement of the all quadrant with respiration, no scar marks, no visible distension present, no tenderness and increased temperature, and no mass palpable on the superficial palpation, no organomegaly, normal ball sound heard. On a percussion, there was normal tympanic note heard. And CVS and CNS system were intact. And based on the history and examination, provisional diagnosis is 69-year male with right-sided incomplete reducible indirect inguinal hernia containing intestine. So shall we elaborate from the first part of the examination? Okay.
Okay. Please go to the provisional diagnosis part. Provisional diagnosis. Okay. You are saying that it is incomplete, reducible, indirect inguinal hernia containing intestine. So, what are the findings that gives you this diagnosis? What are the findings that gives you the diagnosis? Incomplete, reducible, indirect inguinal hernia containing intestine.
While examining the patient, we found
so on inspection. So let's talk about the examination. On inspection, what is the role of the exposure?
Can other people can participate, or shall I answer?
Yeah, anyone who is participating can give the answer. What is the role of proper exposure, and how much part of the body should be exposed? You have clearly written it's from umbilicus to mid-thigh. So what are the differential diagnosis you want to rule out from exposing umbilicus to mid-thigh?
Anyone, please?
We have to
So I think
differentiate either it may be
Okay.
the inguinal hernia or
Okay,
maybe
one
the
is like
hydrocele, or
hydrocele.
if there is any testicular torsion or not, and
Yes,
hematocele,
testicular swelling.
and
Okay,
epididymis and varicocele, any testicular
varicocele,
tumors.
testicular tumors. So from umbilicus, you want to see the umbilical hernias as well. Okay, you have to rule out is there any umbilical hernias. You have to properly expose from the umbilicus and to mid thigh. So in mid thigh you get femoral hernias. In mid thigh you get femoral hernias, and then you want to rule out either it is hydrocele hernia, hydrocele, varicocele, lymphadenopathy, immunal lymphadenopathy. This kind of you want to rule out. So the proper exposure should be done from umbilicus to mid thigh. Okay. Liladhar, we can continue.
Okay,
What are the
now
findings that lead you to believe it is a incomplete? You have said on your differential diagnosis, it is incomplete hernia. What are the findings that suggest it is incomplete hernia?
uh, on palpation, we found that yeah, it's extending the herniated part is extending up to the upper pole of the right testis. That's why it's called.
Up to the upper pole of right testis. So you can clearly differentiate testis from the swelling.
Yes.
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 So it has a peculiar kind of name. Do you know that? What do you call it? One kind of hernia, inguinal hernia, it is strictly limited to the inguinal ligament, inguinal canal. Sorry, it is strictly limited to the inguinal canal. Hernial sac is limited to the inguinal canal. Another is it goes through the superficial inguinal canal and only enters to the scrotum. And another kind of hernia is the hernial sac goes to the scrotum and involves all the part of the scrotum. Do you know what it is called? Leela, any idea?
It's like bucocele, what we call.
Buvinocele is it is only limited to the inguinal canal. Buvinocele is the type of hernia that is only limited to the hernial sac goes beyond the deep inguinal ring, but does not come out from the superficial inguinal ring.
Okay.
And another is funicular that ends in the upper pole of the testis. That you call it funicular. And another is complete that involves the all part of the testis, all part of the scrotum. So if the buvinocele and funicular are type of incomplete hernias. So if you can clearly palpate swelling like hernial swelling and testis separately, then you can say it is a incomplete hernia.
Okay. Okay. So on this, why is it this skin significant and peristalsis significant on
Yes.
inspection?
Another is you have said the shape. Another on inspection, you have clearly mentioned a shape, a pyriform shape swelling. So the shape has also a very clear significance on diagnosing whether it is a indirect inguinal hernia or direct inguinal hernia. The pyriform shape have a significance on inspection. So can you have any guess what does a pyriform shape swelling represent?
Yes, guys, you
Indirect
can.
inguinal hernia.
Indirect type of hernia.
Yes, indirect type of hernia. So what is the shape of the direct hernia?
Spherical.
Globular injury.
Yes,
Spherical.
globular. So the shape has also the significance, and where it extends. He has said It extends from above the medial half of the inguinal ligament down to the scrotum. So it is indirect inguinal hernia. The course of the swelling, so from where it begins and where it ends, that also gives you the uh,
Clue
that gives you
regarding
the idea
direct or
about the
indirect.
that give you idea about the which type of inguinal hernia it is. Okay, and skin over the swelling is normal. He has said on inspection, skin over the swelling is normal. What is the significance of that?
Strangulation can be there.
What are the findings of the skin on inspection over skin in strangulatory hernia?
Erythematous.
Yeah, there is a sign of inflammation, swelling, tenderness, redness. Sign of inflammation will be there. So it has, and he had said it's swelling expands and coughing. The swelling expands and coughing, and it's the swelling expands and coughing. So it shows that it is related with the swelling is anyhow connected to the abdominal compartment, which increases on increasing intra-abdominal compartment pressure. So no visible peristalsis seen. What is the significance of the visible peristalsis?
Content maybe the intestine.
Yes, content. So yeah, if the content is only omentum, you cannot see any visible peristalsis. But if the content is intestine, you can see peristalsis, the peristaltic action. Okay, let's go for.
So the is are every hernia shows expansal impulse?
Every hernia shows expansal impulse. May not be like the obstructed hernias may not show the obstructed hernias may not show the expansal cough impulse because it is already obstructed, so it cannot show expansal. It is not necessarily that every hernia should have expansal impulse.
त्यो obstructed hernia छ भने अनि त्यसमा intestinal content पनि छ भने whether we will see the peristalsis or not.
Peristalsis obstructed, if it is only obstructed you can see peristalsis, but if it is only if it has went to the stage of strangulation you will not see, because the on strangulation the content may lose the vascularity and may not be viable. So on viable segment or content you cannot see the peristalsis. Up to the obstruction, if it is only the obstruction you can see the peristalsis, but like if it has went to the strangulation you cannot if the content is not viable then you cannot see the peristalsis on that context.
The peristaltic will be hypermotile at that time.
Sorry,
the peristalsis will be hypermotile.
Yeah, in obstruction can be hypermotile. Yes.
Okay.
If it is early, can be. If it is early obstruction, that can be a hypermobile.
Okay, on why are we examining this other inguinal region also, and what is it?
Okay, you are also examining inguinal region, and you have also examining inspecting external genitalia also. So please, you can share what is their significance. The inguinal region examination, inspection, left inguinal region inspection, and the inspection of the external genitalia.
Anyone please answer? Can what may be this the reason?
There may be direct or indirect hernia in the same patient.
And why is this significance of arrow looking at penis is position?
So in immunoscrotal swellings, like you have one diagnosis is hydrocele. So in large hydrocele, massive gross hydrocele, so the external genitalia penis will be like buried in the swelling. So, but in the one-sided hernias, it is literally the external genitalia is shifted to the other side. So that can be one significance. And for left inguinal region, if there is like scrotal swelling and you are suspecting scrotal malignancies, then you must check for like lymph nodes as well. In groin swelling, the one differential diagnosis is inguinal lymphadenopathy. So inguinal region should be properly inspected, palpated. So, Lila,
Yeah.
uh, I want to ask one question.
Yeah.
In palpation, you have says a swelling of 4 into 3 centimeters is present above and medial to the pubic tubercle, extending into the scrotum up to upper pole of right testis. Okay, so I want to ask, how would you find pubic tubercle? How would you find pubic tubercle? How would you find pubic symphysis? And how would you find anterior superior iliac spine on palpating? So on
Yeah.
to define the inguinal canal, you have to know anterior superior iliac spine, pubic symphysis, and another is like pubic tubercle. So what? How do you palpate anterior superior iliac spine? One bony prominence, pubic symphysis another prominence, and pubic tubercle another prominence. How do you palpate these structures first?
Yes. Anyone, if are anyone willing to answer?
Is anyone if
To find the pubic tubercle, one we can follow the tendon of adductor longus upward.
yes, you can. So how do you palpate the adductor longus muscle?
Upward.
You will adduct the leg of the patient with the resistance. You will adduct the muscles and you will give the resistance. The patient will ask to adduct the muscle against your resistance, and on the medial aspect of the upper leg, you will find a uh, prominent muscle, that is adductor longus. So, and if you palpate this adductor longus muscle and track it superiorly, you will find it is being joined to a bony prominence, which is pubic tubercle. And another is anterior superior iliac spine. If patient is lying supine and you are palpating the lateral border of the pelvis, the most bony prominence you first find is anterior superior iliac spine. And to find the pubic symphysis, you will first find the umbilicus and go below, just below the umbilicus. And when you find the bony prominence, that is symphysis pubis. So these are the landmarks you usually see. And look, for pubic symphysis, you have to go inferiorly from the umbilicus. For anterior superior iliac spine, you go to the lateral border of the pelvis and find the most anterior and lateral bony prominence, that is ASIS. And another is pubic tubercle. You have to ask the patient to adduct the leg against the resistance, find the adductor longus muscle, and track it tendon superiorly, which is being joined to the pubic tubercle. And he has also clearly, Lila has clearly mentioned that the swelling is present above and medial to the pubic tubercle. So pubic tubercle is a bony prominent that will differentiate two type of hernias. What are they?
That is important question.
Direct and
Pubic
indirect
tubercle.
hernia.
Yes.
Yeah, please. Can you repeat your answer?
Direct and indirect inguinal hernia.
What?
Direct and indirect inguinal hernia.
Uh, uh, um, I think it is inguinal and femoral hernia.
So, where is this femoral hernia is an opening? It's definitely through saphenous opening, right? So it will
If
be
it
below
is
the.
if the swelling is above and medial to the pubic tubercle, it is always inguinal hernia. And if it is below and lateral to the pubic tubercle, it is femoral hernia. If it is below and lateral to the pubic tubercle, that is femoral hernia. So femoral hernia always lies below and lateral to the pubic tubercle. If it is above and medial to the pubic tubercle, it is inguinal ligament. It can be direct or indirect. And if it is below and lateral to the pubic, the swelling, if you find the pubic tubercle and if you relate the swelling with the pubic tubercle, you can identify whether it is inguinal or femoral hernia. So by palpating, you can get one diagnosis.
So any
So,
more question
and
on this palpation part?
okay.
So these points are very important. So why do you think these points we have written here? Do you want to ask? You can. So this get above the swelling. Rajda, can you elaborate on this part?
Okay. Get above the swelling. When the in hernia, to get above the swelling, you have to do what is the examining is you have to start from the inferior edge of the swelling, distal edge of the swelling. So, and you usually palpate anteriorly with your thumb and posteriorly with your index finger and middle finger, and you will drag it up and up to the root of the scrotum. And if you can get above the swelling, that means if you get the cord structure, you say I can get above the swelling. If you can't get the cord structure, you just feel the swelling, then you cannot get above the swelling. In hernia, in immunoscrotal swellings, in any kind of immunoscrotal swellings which has been started from the inguinal region and extend up to the scrotum, you will not get above the swelling. You will not you will not find the cord structures, so you will not get above the swellings. But in only scrotal swellings, just like hydrocele and other things, you will get the cord structure. You will feel or you will palpate the cord structure and you will get above the swelling. So you can, after this for to test the get above the swelling, that means you can differentiate it, either it is the immunoscrotal swelling or just a scrotal swelling. So you can differentiate it. The swelling is either in immunoscrotal swelling or a scrotal swelling.
Okay. Anyone can ask. Want to ask any question on this?
If in this case, if you are not getting the possible, not getting above the swelling, that means it is any kind of immunoscrotal swelling. And he's also saying that he tested his feeling separately, so that is uh, incomplete. So testis you are feeling, testis you are palpating separately. That means the hernial content has not engulfed whole of the scrotum, so it is not complete. It is incomplete. expansal coughing pulse is present, and swelling is reduced manually with the gargling sound. Okay, that means swelling is reduced. So uh, in your provisional diagnosis, you have said it is a reducible. So you can reduce. How can you reduce immunoscrotal swelling? How will you reduce immunoscrotal swelling?
Yes, please, anyone?
In many cases, it may reduce itself by the lying down, and in majority of
Yes,
cases,
one first is you will always examine the patient either standing, then you will ask the patient to change the position either by sitting or by lying down, and by changing the position you will look whether the swelling is reduced or not. Okay, the first is changing position. You can tell the patient to lie down, and if it is not reduced on lying down, what will you do?
we can flex the thigh of the affected side and
Okay, that
adduct
is the relaxing the musculature. You can do it.
to adduct and rotate it internally.
Okay, and one is like you can relax the abdominal musculature, which can also leads to the reduction of the swelling. And if it is not reduced by that also, then you will go for manipulation, manipulating by external manipulation also. Sometimes they can give the history that it is not reduced automatically. The patient has to manipulate it through the scrotum, then only it is removed. That will give you diagnosis of impending obstructed hernia. So if it is going spontaneously on lying down, then that is okay. But if some patient has said that it has to be manipulated by on his own, then it gives you idea about the impending obstructive hernia. And the gargling sound may be due to the content of the intestine. It has to be auscultated for to know about the gargling sound, which can give you the diagnosis of the what content is it inside. It can be intestine. Okay,
That's like this. How will we reduce the umbilical hernia? This is one test, right? That
yes.
he,
This umbilical hernias. At first, you have to typically you have to elevate the patient's head. Patient's head is on lying down position. The patient head is elevated, which relaxes the muscle abdominal musculature, and then the hernial content is reduced. So you have to on lying down position, the only the head is elevated and the abdominal musculatures are relaxed, and then umbilical hernia will be reduced.
What is the difference between reducing omentum and intestine?
Yes.
What is the difference we feel when we reduce an omentum and another the intestine? And why?
Okay. On reducing omentum, the first part of the swelling, goes easily, and the omentum and the last part of the swelling, distal part, you will have difficulty reducing it on omentum. On intestine, the first part of the swelling, it will go with difficulty, but the latter part, it will go with ease. It will go with ease.
Why this happens? What's
So
the
like
reason?
in omentum, there is the continuity. The continuity is there. The proximal part is continue with the so it can be easily reduced. The proximal part can be easily reduced, but the later part, distal part, which has come out, it will take some effort to reduce, because it is not in continuity with the intestine. So swelling is there, so there will be difficulty in intestine. There it will be very difficult to send the first, then it will go easily after one. The proximal part goes, the proximal part will take the distal part and goes easily.
Anyone further question on this part, on examination part?
Okay, and like we can go to the deep ring occlusion test. If anyone can elaborate deep ring occlusion test, it will be.
Whatever you know, you can share, and further you will add on or correct on you.
So any will say, or I have to I will say the examination part, the deep ring occlusion test.
Okay. So first we have to know the anatomy, right? So where do we found this deep ring, superficial ring, saphenous opening, anatomical landmarks?
The superficial ring is above and lateral to the pubic tubercle, and the deep ring is 1.25 centimeter above the mid-inguinal point.
Okay. Then what is mid-inguinal point and mid-point of inguinal ring? Points are different, right? So how are they different? What's the difference?
Mid-inguinal point is midpoint of line joining anterior superior iliac spine and the pubic symphysis.
So what is
By knowing this anatomy, we can ask the patient to stand up and cough with the finger of examination occlusion ring. If swelling immediately, it is direct hernia, and if swelling come out only when the finger is removed, it is indirect hernia.
so? What is deep inguinal ring?
Sorry for the disturbance. Background noise. Okay.
Can you hear me?
Yes, yes. Yes, anyone can answer how deep inguinal ring is formed and how superficial inguinal ring is formed.
So like first, to know about the deep ring occlusion test, you have to know about what is deep inguinal ring. So deep inguinal ring is like a it is a condensation of transversalis fascia. It is only the condensation of transversalis fascia. It is condensed and make an opening. So it lies about 1.25 centimeter above the like mid inguinal ligament. Mid-inguinal ligament. So in the mid-inguinal ligament is the line joining the anterior superior iliac spine and pubic symphysis. I have already told you like how to approach the anterior superior iliac spine and pubic symphysis. So it is a deep inguinal ring. So the main and the another is superficial inguinal ring. Superficial inguinal ring is like medial most opening of the external oblique aponeurosis. The medial most opening of the medial most and inferior opening of the external oblique aponeurosis. It from where usually the cord structure enter the scrotum. And these two structures should be noted to perform like deep uh, deep ring occlusion test, Siemens test. For Siemens test, you have also know the another is like the femoral canal. The femoral canal usually it's not the like that, usually lies uh, below and lateral to the pubic tubercle. So these three anatomical landmarks should be noted to perform the deep ring occlusion test and Siemens test. To perform the deep ring occlusion test, first you have to reduce the swelling, either it by either by keeping the patient in the lying down position or by externally manipulating the swelling. First you have to reduce the swelling, and if the swelling is reduced, then you will occlude the deep ring by pressing the thumb finger or index finger in the in the in the position of the deep inguinal ring. It is like 1.25 centimeter above the mid inguinal line. So you will occlude this and ask the patient to cough, and if it shows the swelling medial to the medial to your finger, then it is indirect hernia. And if you only can feel the impulse but the swelling does not come out, then it is indirect inguinal hernia. If it comes medial, it is direct inguinal hernia. It is coming from the Hasselbalch triangle. And if it is not the swelling is not coming but you can feel the impulse, then it is indirect inguinal hernia. It is coming from the deep inguinal ring. It is coming from deep inguinal ring. And the similar principle on the Siemens test, you have to put the hernia should be reduced, and you have to put the three fingers in three positions. Index finger in the deep inguinal ring position, middle finger on the superficial inguinal ring position, and the ring finger on the femoral canal position. So index finger will be kept 1.25 centimeter above the mid inguinal line, and middle finger is kept 1.25 centimeter above the pubic tubercle, and this ring finger will be kept 1.25 centimeter below and lateral to the pubic tubercle. And after reducing the hernia, you will ask the patient to cough and feel the impulse. Where will it be felt? In that way, it will be, if it is in the index finger, it is indirect inguinal hernia. If it is in the middle finger, it is direct hernia. If it is in the ring finger, then it is femoral hernia.
So we're examining both bilateral inguinal region.
Yeah, examination should be done on the bilateral ways. Sometimes that can we may have a occult hernias on the contralateral side. In one hernia, in one side, you can feel find the hernias, but sometimes there can be occult hernias which is not diagnosed. So therefore, you have to examine both inguinal region. If you find the immunoscrotal swelling in one side, then you must examine another immunoscrotal region as well.
Why is this external examination of external genitalia significant?
Sorry?
What is the significance of examining this external genitalia?
Okay.
Anyone can please share their views. What do you know about this? Why are we examining testes, spermatic cord, penis, inguinal lymph nodes?
First of all, to differentiate either it is complete or incomplete hernia.
Okay.
Yes.
Then it may be the only scrotal swelling, not the inguinal scrotal swelling.
Okay.
And, that's all.
The scrotal skin examination is necessary to identify if any inflammatory changes are occurring or not. In either it is in testis or in due to the obstruction or strangulation. The scrotal skin examination should be done for possible inflammatory changes, inflammatory markers. The testis should be examined to rule out whether there is any testicular mass, whether there is any testicular torsion, whether there is hydrocele or anything like that. Spermatic cord, sometimes there can be encysted hydrocele. So spermatic cord should be filled as well. If there is isolated swelling in continuity with the spermatic cord, then we should suspect encysted hydrocele. And in penis, it should be examined for any burring or any malignancies. Sometimes the carcinoma of penis can also lead to the immunoscrotal swelling. So penis should be thoroughly examined. And urethral strictures can also lead to the symptoms like prostatic enlargement. The urethra should be urethral examination should be done. Sometimes you can feel urethral mass that can lead to the inguinal swelling. Inguinal lymph nodes are very necessary to rule out lymphadenopathies and possible malignancies. So that's why inguinal lymph nodes should be examined. Digital rectal examination is must in cases of hernia, when it should be done to rule out like obstructive features. Sometimes if there is obstruction, there will be ballooning of the rectum. There will be ballooning of the rectum, so that can lead to there is the possible obstruction. And another is you have to look for the prostate. So if there is enlarged prostate, uh, you have to do the prostate examination and palpate in the anterior aspect and see its contour, see its consistency, see any possible mass. Uh, and so the prostate examination should be done in all cases of inguinal swellings. Sometimes the rectal carcinomas, rectal mass can lead to the inguinal lymphadenopathy as well. So if you suspect any inguinal swelling, any immunoscrotal swelling, you have to you have to do the digital rectal examination.
Based on our history, so what may be the possible differential diagnosis?
So what is the possible treatment? So from here, the provisional diagnosis has been done 69 years male with right-sided incomplete reducible indirect inguinal hernia containing intestine. So what are the possible other investigation you would want to send, and what will be the treatment modality?
Yes, before that, guys, please, what may be the differential diagnosis based on
Yeah.
this history?
Other differential, possible differential diagnosis.
Yeah, you can say.
It may be direct hernia, inguinal hernia. It may be femoral hernia. Then hydrocele cord and inguinal lymph node enlargement.
So which one is common is more in female and male?
Both same, I think. Inguinal hernia is the same.
Based on this age group, this one is more common in which age group? First, can you talk about this process of vaginalis? We see more commonly this indirect hernia in children.
So I want to add some of the differential diagnosis. One is varicocele. Varicocele can also lead to the immunoscrotal swelling. Another is a lipoma of the cord. So if there is any lipoma on the cord, you will also feel it as a like immunoscrotal swelling. Another is epididymal cyst. And another is like incystate hydrocele. These are the other differential diagnosis. In this context, I think varicocele can be there, incystate hydrocele can be there, epididymal cyst can be there, lipoma of the cord can be there.
And how do we proceed further for investigation part?
So what are the role of ultrasonography in this case?
Can anyone please give their opinion? What might be the role? What are we checking for? What do you think?
If hernia is not palpable, we can do USC.
Okay. If you are not, if you are clinically not sure whether it is a hernia or incystate hydrocele, is there any role to do ultrasonography?
Anyone? Okay, then you
have done examination. By this examination, you cannot rule out whether it is lipoma of the cord or whether it is inguinal hernia. Should we proceed for ultrasonography?
Yes, you can proceed. Right.
So like hernia is okay. Hernia is clearly a clinical diagnosis. It is not a radiological diagnosis. You have to clinically rule out whether it is hernia or not. Sometimes, if you are like you have to you don't know about the content. You can know the hernia, but you don't know the content. Sometimes it can be lipo. Sometimes it can be lipoma. Sometimes it can be urinary bladder. Sometimes the content can be appendix. Sometimes the content can be content can be Meckel's diverticulum. So in this kind case, if you are not sure about the content, then you can go for ultrasonography. What are the contents? Sometimes the content can be urinary bladder, sometimes the content can be appendix. In that sort of cases, if you are not sure what are the contents, then you can go for ultrasonography.
And further investigation?
For other investigation which you want to send for the, not for the diagnosis, for the management.
So we sent all three of investigation, right? And what is the management in this case? Anyone can share? And what is the definitive management in case of inguinal hernia? And which one is most nowadays preferable for the treatment?
Herniaplasty, you can do.
Okay, guys, you know what do you mean by this miss? What is miss? This is the one of the question we have asked. We have been asked by our examiner. What? Yes.
I think first we should know what is the surgical management.
Okay. Okay. Yes.
Okay,
You can
the
proceed.
management of the hernia is usually the surgery. So, like first of all, there is two treatment modalities. One is herniatomy, and another is herniorrhaphy. The herniatomy is just dissection of the hernial sac and ligating of the hernial sac. It is usually done in children, as there is no clear-cut demarcation between the superficial inguinal ring and deep inguinal ring in pediatric age group. So the treatment of choice is of congenital hydrocele, and congenital hernia is herniatomy. Another in this age group, the 69 years male, the treatment modality is surgery, and surgery is hernioplasty. Hernioplasty, there is two types of hernioplasty. One is mesh repair, and another is herniorrhaphy. Herniorrhaphy means anatomical closure, and another is hernioplasty means anatomical closure with additional reinforcement with polypropylene mesh. And the approach to the hernioplasty is by two approaches. One is anterior and another is posterior approach. And we can say it either it is open approach or laparoscopic approach. In anterior approach, there can be hernioplasty with the mesh, or herniorrhaphy with anatomical closure, which is done by open method. And posterior approach, the posterior approach is either typically laparoscopic approach. So the laparoscopic approach is called transabdominal preperitoneal mesh repair, and another is totally extraperitoneal mesh repair. So there are these. First, in the pediatric age group, there is only herniatomy can be done. Nothing other, no other things can be done because of the superficial inguinal ring and deep inguinal ring are very close to each other and they cannot be differentiated. That's why only herniatomy can done in pediatric population. In older adult age group, we can go for either herniorrhaphy or hernioplasty. And the herniorrhaphy means like you will do the anatomical closure. You will not use any mesh, but you will close the you will close the hernial sac and repair the defect with the non-absorbable sutures. You will reinforce the defect by the original tissue, that is herniorrhaphy. And another is hernioplasty. You will do the defect to close the defect, but you will add the additional reinforcement as a polypropylene or any surgical type of mesh. And the repair can also be done by either anterior approach or posterior approach. Anterior approach, we usually do it by open method, and posterior approach we usually go it by laparoscopic approach. In like anterior approach, there is the most commonly used technique is Liechtenstein tension free Liechtenstein tension free mesh repair. That is, we usually perform the Liechtenstein uh, tension free mesh polypropylene mesh repair. We usually perform that. And another is uh, modified Bassin's repair, Soldis repair, which is the repair by without using chlorine. It is orniorrhaphy. We don't use polypropylene in case of Bassin's and Soldis repair. In Bassin's and Soldis repair, we usually reinforce the transversalis fascia. We take the continuous suture with we take a continuous suture with the transversalis fascia and inguinal ligament, then conjoint tendon and inguinal ligament, and we will reinforce the conjoint tendon with the external oblique aponeurosis, and external oblique aponeurosis will be closed. It will be the layer wise repair. So the layer wise double breasting and suturing will be done to close the hernial defect. So that's why the Bassin's and Soldis are the herniorrhaphies, and Liechtenstein is hernioplasty.
What may be the possible complication after the repair?
Yeah, we can discuss about the possible complication of the hernioplasty surgery. The possible complication you can get after the hernioplasty surgery.
Okay, guys, you can participate. You can say any one complication, any type of surgery.
Any complications you know.
Hemorrhage.
What?
Hemorrhage.
Hemorrhage, yeah. We are very close to the inferior epigastric artery. Yeah, there can be bleeding.
Recurrence.
Yes,
Wound
recurrence.
infection. Wound infection.
Yes. Wound infection. There is a greater chance of the wound infection. It is very close to the perineum, so not a hygienic area. Chances of wound infection is there.
Iliohypogastric nerve entrapment.
Yeah, entrapment of the iliohypogastric, ilioinguinal and genital branch of genitofemoral nerve. Iliohypogastric as well, ilioinguinal as well, and genital branch of genitofemoral nerve. This can be injured because they are in our surgical site. This can be trapped either by mace or by scar. There can be injury to the vas deferens because we have to identify, we have to separate the cord structure from the hernial sac. So while separating the cord structure from the hernial sac, in the cord there can be vas deferens and there can be injury to the vas deferens. Another is there can be injury to the testicular vessels. While dissecting the sac, there can be injury to the testicular vessels. So there, if the testicular vessel is injured, there can be what might be the complication if while doing hernial surgery, if the surgeon injures the pampaniform plexus of the testicular veins, then what will be the possible complication that can arise in future? So the pampaniform plexus will drain the blood from the testis. So if you injure the significant amount of pampaniform plexus of veins, then the venous drainage will be impaired. So first there will be the testicular swelling, and later there will be the, and on future this can lead to the testicular atrophy.
So we are close to the end of the end of our
And
presentation.
another one complication is if there is a if the content of the hernia is sometimes urinary bladder, there can be urinary bladder injury. If the content is bowel, there can be the bowel injury while dissecting and ligating the sac.
There may be these possible complications.
In open hernia repair, there is a standard incision. Do you know the standard incision from where to where it extends? There is a standard incision in the open hernia surgery. In the open hernia surgery, there is a standard incision the most surgeons usually give. Do you know from where to where it extends?
Anyone, please, if you know, you can answer.
So the open hernia surgery, the incision usually extend from the pubic tubercle 1.25 centimeter just above the inguinal canal, and it extends from the medial two-third of the inguinal ligament. So that is just 1.25 centimeter superior and parallel to the inguinal ligament, and it extends from the uh, pubic tubercle to the medial two-third of the inguinal ligament. Inguinal canal, sorry, medial two-third of the inguinal canal. So it will give the proper exposure of the superficial inguinal ring as well, and it will give the proper exposure of the deep inguinal ring as well. So it should be 1.25 centimeter above the inguinal mid-inguinal line, and just medial two-third of the mid-inguinal, just two-third of the inguinal canal, exposing just two-third of the inguinal medial two-third of the inguinal canal.
Okay, you have any questions? We're at the end of the presentation. Regarding the presentation part and further question. Anyone, please?
You were going to explain about the mesh. So could you explain?
What?
त्यो मेशको बारेमा भनिदिनु न.
So mesh is an additional support which we usually place above the above the transversalis fascia. So to provide the additional support to the So the it is usually made up of non-absorbable synthetic material, that is polypropylene, and it is usually in most of the cases its length is in 15 into 8 centimeter in 15 into 8 centimeter in size, and it is usually the polypropylene non-absorbable material is used, polypropylene, and the way it gives the support is not by the on healing process. It usually get fibrosed. Okay, so on fibrosis it fibrous with the transversalis fascia. On fibrosis after 6 months to 1 year, then it only gives the additional support to the deep inguinal ring and the extra the Hasselblad triangle and the posterior wall of the inguinal ligament. So it is usually the use of non-absorbable materials like synthetic non-absorbable materials. Usually it is made up of polypropylene, and the mode of action by which it gives additional support is by fibrosis with the tissues. On long run, it gets fibrous with the tissues and it gives the additional support. That's why we don't give tension while suturing the polypropylene, because if it additionally get fibrous and may become tense. So if we give the tension suture to fix the mess, it usually result in the post-operative pain. Any other things you want to know about mesh, please?
No, thank you.
दाइ एउटा क्वेसन थियो
भन न।
के रे हर्नियाको कन्टेन्टहरु अनयुजुअल कन्टेन्टहरु छ भने जस्तै सिग्मोइड कोलनहरु एपेन्डिक्सहरु अनि त्यो लिटर्स हर्नियामा त्यो मिकेल डाइभर्टिकुलमहरु पनि प्रेजेन्ट हुन सक्छ नि त।
हजुर हजुर हजुर।
त्यसलाई रिमुभ गरिन्छ कि हर्नियासँग त्यो भित्र कन्टेनरलाई रिमुभ गर्ने कि एपेन्डिक्स भित्र?
The thing is, we will check for the viability of the tissues that is as a content. If there is the content is omentum and it is extensively necrotic, we'll take it out. If the content is only omentum, just omentum, but it is very necrotic, okay, then we will take it out and we will not reposit it in the abdominal cavity. But if the content is viable, if the appendix is viable, and not inflamed, then we can reduce it to the abdominal cavity. Or if it is the appendix has come to the tissue and it is inflamed, then we will do appendectomy and reduce the content to the abdominal cavity. So the main principle is we will check for the viability of the content. If the content is viable, we'll reduce it. If the contents are viable, we will reduce it. Just like if the mecal diverticulum cut, and if the mecal diverticulum is viable, still viable, and if there is no need of surgery for the mecal diverticulum by the size or any other cause, then we will not do the surgery. We will reposit in the abdominal cavity and we will repair the hernial defect. But if there is like ball and omentum is still the omentum is necrotic, then we will go for the resection of the content and we'll do as per required. If the sigmoid colon is there and sigmoid colon is gangrenous, then we will do resection of the gangrenous content and we will do hemicolectomy along with the tendon, along with the hernia repair.
Thank you, Dai.
So, Achal, you are at the E or what?
Any queries, then participants are requested to ask. Hope all the queries has been answered. We are very thankful for your presence. From the Grey Medicos team, we have prepared a small token of love for you. Both, I request Roshan to display the token of love for Dr. Here's a small token of love. We would like to hear a few words about today's program and Gray Medicals from you, Dr. Rajesh Adhikari, sir.
Thank you for giving me this opportunity to share some of my knowledge about the inguinal hernia to all of you. I think I want to thank Dr. Leeladhar for giving me this platform, share some of my knowledge to you all. I think these kind of platforms are very interactive. I find it really fruitful for all of you guys. And if this kind of platform can be interactive, then it can be a quite good learning platform for all the medical students. Thank you, the Gray Medicals and Dr. Leeladhar for giving me this opportunity. Thank you.
Thank you, sir, for those inspiring words. I request Roshan to share it for Dr. Leeladhar, sir. Sir, we would like to hear from you as well.
Okay, thank you. Thank you, the Gray Medicals team. I feel very glad when I think Achal came to me to present on some topic for our team. We have created this online platform from. So I keep changing the date, right? I still remember this. I keep changing the date, and it was not still free because this our duty and our senior, the Dr. Rajesh, with duty done sometime. It will be on the same day like that. It was not. It was happening like that. That's why we planned for today. Okay, I will first of all thank you to all for giving us opportunity to share whatever we know. I think we know that we don't know. We may not know what we have said, or we may not said absolutely right. But you can check your textbooks or other references. Okay, so, because anyone can mistakenly may have verbalized any wrong things here. So for that, I feel sorry from my side or any part of yours. Okay, and then further, and you also keep informing us if any other topic you want to or you want us to present in other department from other department. Also, we can also share to with our friends, or we can do in further days. Thank you. Thank you for this opportunity. Thank you, Rajesh, for being here with us with your valuable insight and your valuable time, and the Gray Medicals team. Thank you.
Thank you so much, guys. We hope to have many fruitful discussion with you in future as well. Despite your busy schedule, we are very grateful for your presence. Lastly, I thank all the participants for their active participation and hope that they shall join in upcoming webinars as well. I request host to end the meeting. Thank you so much.